It's 3:17 in the morning, you're fast asleep, and you have no idea what's happening inside your chest. Deep inside your left anterior descending artery, the one we call the widowmaker, a microscopic crack just formed in a plaque wall that's been building for 11 years. You won't feel it. Not yet. My name is Dr. Robert Caldwell. I'm a cardiothoracic surgeon with 30 years in the operating room and over 2,000 chests opened. Tonight, I'm going to tell you something most cardiologists don't have time to cover in a 15-minute appointment. The most dangerous hours of your day are not the hours you're awake. They're the 8 hours between when you close your eyes and when that alarm goes off. While you think your heart is resting, your heart never rests. What changes is the battlefield, and that battlefield is almost entirely controlled by what you did before you went to bed. We're going to walk through this hour by hour, starting at 10 p.m., ending at 7 a.m. Early in this timeline, I'm going to mention something that seems completely unrelated to your heart. A glass of water on your nightstand. Don't let it go. It matters more than anything else I'll say tonight. You think the night starts when you fall asleep. It doesn't. It starts the moment you sit down after a heavy dinner. If that dinner was red meat, pasta, or anything fried, your digestive system is still running full operations. Your heart is pumping harder to send blood to your gut. Triglycerides in your bloodstream are spiking, and now you're telling your body to sleep at the same time. That's a direct conflict. Two opposing cardiovascular demands, digestion and recovery, happening simultaneously inside an aging system. After 60, your arteries are not the flexible tubes they were at 35. I've seen both on the same table under the same lights. Young arteries behave like fresh garden hose, pliable, elastic, forgiving. Arteries in their 7th decade are something else entirely. They stiffen. Collagen replaces elastic tissue at the cellular level. They become pipes, and pipes under pressure don't flex. They crack. There's one more thing happening at 10:30 p.m. that almost nobody considers. Blood pressure medication. If you took it this morning, and most people do, by 10:30 tonight, that drug is wearing off. The hours ahead, the hours of maximum cardiovascular vulnerability, are the hours you're least protected. In a healthy cardiovascular system, something critical happens around midnight. Blood pressure dips, heart rate slows, the arteries relax. The parasympathetic nervous system, your rest and repair system, takes command. Cardiologists call this nocturnal dipping. It is the nightly maintenance your heart absolutely depends on. But after 60, that dip becomes unreliable. In 30 to 40% of older adults with hypertension, it doesn't happen at all. We call those patients non-dippers. Some of them actually see their pressure rise during sleep. We call those patients reverse dippers. Non-dippers have dramatically higher rates of stroke, heart attack, and left ventricular hypertrophy. That's when the heart muscle thickens from overwork. A change that looks like strength but is actually early failure. Here's the brutal irony. These same patients have perfectly normal readings at their 2 p.m. doctor's appointment. Doctor smiles and says, "See you next year." That night, while sleeping, their systolic pressure runs at 155 for 6 hours straight. Their arteries are under assault while everyone assumes they're fine. This is why so many people end up on my table looking genuinely surprised. No warning signs, normal checkups. Then 3 a.m. By 2 in the morning, most people are in their deepest sleep, non-REM slow-wave sleep, blood pressure at its lowest, heart rate at its slowest. And your blood has been quietly doing something nobody told you about. It's been thickening. You haven't had a drink of water in 4 or 5 hours. Your body is losing fluid through breathing and normal cellular processes. As blood loses volume, it becomes more viscous, more like cold syrup than water. Combine that with a cardiovascular system running on minimum. Heart rate low, pressure at its nadir, blood moving slowly through arteries already narrowed by years of plaque. Picture a clogged interstate at 2 in the morning. Your red blood cells moving slowly through a narrowed, congested highway in thick, sticky fluid. That is your coronary circulation at 2 a.m. if you went to bed mildly dehydrated. That glass of water on your nightstand, that's not a comfort habit. That's cardiovascular engineering. I'll explain exactly why, right after we talk about what's happening in your throat at this same hour. Does your partner snore? Do you? After 30 years in this field, I treat heavy snoring as a cardiac red flag until proven otherwise. Sleep apnea is present in over 30% of adults over 60. The vast majority have never been diagnosed. They have no idea what's happening to their heart every night. Here's what an apnea episode looks like from the inside. You stop breathing, sometimes 40 seconds or longer. Oxygen drops sharply. Your brain fires an emergency stress response. Adrenaline, cortisol, a sudden violent spike in heart rate and blood pressure. Your heart jolts from resting to emergency mode in seconds. Then you breathe again, and 20 minutes later, it happens again. In severe cases, 50 or 60 times per hour. All night, while you think you're sleeping. Research shows sleep apnea is directly linked to a threefold increase in heart attack risk. It keeps nighttime blood pressure elevated in patients whose pressure should be dipping. If you snore heavily, if anyone has watched you stop breathing in your sleep, if you wake exhausted after 8 full hours in bed, get evaluated. A sleep study is not optional after 60. It is part of cardiac care. We've arrived. 3 a.m. This is the hour I think about on the operating table. Something shifts at this precise hour inside your circadian system, the biological clock controlled by the suprachiasmatic nucleus in your brain. The body begins its pre-dawn preparation. The very first signal it sends is a quiet early release of cortisol, not a flood, just the beginning of a slow tide that will swell over the next 3 hours. At 3 a.m., rising cortisol begins to sensitize your coronary arteries to catecholamines, to adrenaline. It primes them, makes them reactive, makes them far more likely to constrict sharply when the sympathetic system kicks in at full force. At the same time, platelet aggregability, the tendency of blood platelets to clump and form clots, follows its own circadian rhythm. It begins rising rapidly between 3 and 4 in the morning. Your clotting tendency is increasing while you sleep, while your blood is already thickened by dehydration, while your arteries are sensitized by cortisol, while your blood pressure medication has largely worn off. This is not a single risk factor. This is a convergence, a perfect storm assembling in the dark, one element at a time. At the center of that storm sits a vulnerable plaque, a deposit of cholesterol and inflammatory cells that's been accumulating inside a coronary artery for years. It may block only 40% of the artery. Your last stress test was normal because it doesn't restrict enough flow to trigger symptoms during exercise. But its fibrous cap, the thin wall separating the plaque's interior from your blood, is inflamed and thin. At 3:17 a.m., rising cortisol increases hemodynamic shear force on that arterial wall, and that cap cracks. The contents of the plaque are exposed to your blood. Your platelets, already at peak aggregability, immediately begin building a clot. Within minutes, a microscopic crack becomes a rapidly growing thrombus. If the clot grows until it fully occludes the artery, that's a STEMI, a full heart attack, and the window between that 3 a.m. crack and the moment most people reach a hospital is long, because they're asleep. Because by the time symptoms break through the denial, it's often past the golden treatment window. At 4 a.m., your body releases peak concentrations of plasminogen activator inhibitor 1, PAI-1. PAI-1 is your body's clot-dissolving suppressor. It blocks the system your body would normally use to break down a dangerous clot. Think of it as your building's fire sprinklers being switched off at the exact moment the fire starts. PAI-1 peaks at 4 a.m. in healthy adults. In patients with hypertension and insulin resistance, conditions common after 60, PAI-1 levels run chronically higher and peak even more dramatically at this hour. The Framingham Heart Study data is unambiguous. The risk of sudden cardiac death is 70% higher between 7 a.m. and 9 a.m. compared to any other time of day. But the cascade that creates that death began at 3, at 4, while everyone was sleeping. By 5 a.m., the sympathetic nervous system is coming fully online. Noradrenaline starts rising, heart rate increases. The renin-angiotensin system activates and begins raising blood pressure. For a 32-year-old with elastic arteries, this pre-dawn preparation is elegant, the body preparing for a new day. For a 68-year-old with stiff, plaque-loaded coronary arteries and subtherapeutic medication levels, this same process is a mechanical stress test happening in total darkness. Every pressure increase is another wave of force against walls that cannot absorb it. Every coronary constriction is demand placed on a blood supply already fighting through narrowed, calcified corridors. If that person's bedroom was too warm, causing overnight sweating and fluid loss, if sleep apnea fragmented their rest 50 times, if they had a heavy dinner at 9 p.m., each factor doesn't add to the risk, it multiplies it. The most dangerous cardiovascular window peaks between 6 and 9 a.m., but that wall was built the night before, and it has 5 bricks. Finish dinner by 7 p.m. A meal eaten late and followed immediately by lying down keeps your cardiovascular system in active digestive mode precisely when it needs to begin recovery. You are adding fuel to a fire you cannot yet see. The Hygia chronotherapy trial followed over 19,000 patients for 6 years. Patients who took blood pressure medication at bedtime instead of in the morning had 45% lower risk of major cardiovascular events. Ask your doctor one specific question. Should I be taking my blood pressure medication at night? That 2-minute conversation may be the most important cardiovascular decision you make this year. If you have any sign of sleep apnea, get formally evaluated. CPAP therapy produces measurable reductions in blood pressure, lower rates of atrial fibrillation, and significantly improved nocturnal dipping. One device used consistently changes what happens to your heart between 2 and 6 every morning. Keep your bedroom between 18 and 22 Celsius, 65 to 72 Fahrenheit. Too warm and you sweat away the fluid volume your blood needs to stay thin. Too cold and vasoconstriction raises nighttime pressure against an already burdened system. And now, we're back to it. That glass of water. At 2 a.m. your blood is at its thickest. 4 to 5 hours since your last drink, losing fluid volume steadily all night. Thicker blood moves more slowly, clumps more readily, and in arteries already narrowed by plaque, dramatically raises the probability that a forming clot completes the occlusion. 1 full glass of water before bed, a second glass on the nightstand. When you wake at 2 a.m. with mild thirst, your blood is asking for exactly what your heart also needs. Do not talk yourself out of it. You open your eyes, the alarm goes off. And in that precise moment of cortical arousal, your brain fires a shot of adrenaline and noradrenaline. Blood pressure surges. Research shows the average systolic rise in the first hour after waking is 14 millimeters of mercury in hypertensive patients. An exaggerated morning surge, a rise greater than 55 millimeters from the overnight nadir, is an independent predictor of stroke, heart attack, and cardiovascular death. If you stand up too quickly, gravity pulls blood toward your legs. Your baroreceptors, the pressure sensors in your vessels, respond more slowly after 60. There's a window of 5 to 7 seconds where your brain receives meaningfully less blood. You feel it as brief dizziness, a slight darkening at the edges, a moment of unreality you've learned to ignore. Most people attribute it to age. Often it isn't age, it's biology responding to a night that wasn't set up correctly. I have stood at an operating table at 4:30 in the morning, holding a heart that stopped because of a clot that began forming at 3 a.m. I have spoken to families in hospital corridors at dawn who said goodnight to this person 6 hours earlier with no idea anything was wrong. I have read their charts afterward, and every time, the timeline was there. The late dinner, the worn-off medication, the airway that collapsed silently 40 times per hour, the bedroom at 76 degrees, the blood that thickened overnight because no one told them the glass on the nightstand wasn't optional. These are not exotic risk factors. These are the background noise of millions of ordinary American evenings. Accumulated night after night, year after year, they become a 3 a.m. crack in a plaque wall that nobody saw coming because nobody knew to look. You now know. Look, I'm a surgeon, but I'm not your doctor. What I've shared is educational, not a prescription. Before changing any medication timing, talk to your own physician first. They know your full history and your complete clinical picture. What I want is for you to walk into that office armed with the right questions, because that knowledge changes the conversation, and that conversation changes the outcome. Take care of that heart. It has been beating for you every single second of every single night of your entire life without ever asking for anything in return. Tonight, give it what it needs.